Hello everyone, I'm Dr. Bhagayee from Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College and Hospital, and I will be talking about shock. So this is the table of contents. We will be going through what is shock, the types of shock, etiology and pathogenesis of shock, stages of shock, the pathophysiological changes that happen. We will go through the classification of shock. We will look at hypovolemic shock, septic shock, traumatic shock, neurogenic shock, distributive shock, anaphylactic shock, and burn shock. And ultimately, we will look at the treatment of shock. Shock or cardiovascular collapse may be defined as a condition in which circulation fails to meet the nutritional needs of the cells, and at the same time, it fails to remove the metabolic waste products. It is a final common pathway for many potentially lethal clinical events, including hemorrhage, trauma, burns, large myocardial infarctions, massive pulmonary embolism, and microbial sepsis. It is also defined as the clinical state of cardiovascular collapse characterized by an acute reduction of effective circulating blood volume and adequate perfusion of cells and tissues. The end result is hypotension and cellular hypoxia, and if it is uncompensated, it may lead to impaired cellular metabolism and death. Primary or initial shock is a transient and usually benign vasovagal attack resulting from the sudden reduction of venous return to the heart caused by neurogenic vasodilation and consequent peripheral pooling of the blood. It can occur immediately following trauma, severe pain, or emotional overreaction, which may be due to fear, sorrow and surprise, or even sight of blood. Clinically, the patient develops the signs and symptoms similar to that of syncope. The patient may have unconsciousness, weakness, sinking sensation, pale and clammy limbs, weak and rapid pulse, and a low blood pressure. Primary shock may be labeled as a severe form of syncope. It lasts from a few seconds to a few minutes. Shock causes reduction in cardiac output or effective circulating blood volume. This leads to systemic hypoperfusion. This in turn leads to hypotension, impaired tissue perfusion, and cellular hypoxia. Initially, cellular hypoxia may persist and cause irreversible tissue injury and death, but in the initial stages, it causes reversible cellular injury. Stages of shock. The deterioration of circulation in shock is a progressive phenomenon and can be divided arbitrarily into three stages. The non-progressive, which is the initial or compensated and reversible shock, progressive decompensated shock, and decompensated irreversible shock. Widespread vasoconstriction, which is in response to reduced blood flow and tissue anoxia. The neural and hormonal factors, example baroreceptors, chemoreceptors, catecholamines, renin, vasoexcitor material from hypoxic kidney are all activated. These all bring about vasoconstriction, particularly in the vessels of the skin and abdominal viscera. This is a protective mechanism as it causes increased peripheral resistance, increased heart rate, and increased blood pressure. Irreversible stage. It is a progression of shock to a stage where therapy does not help. The brain fails to function due to cerebral ischemia. Even infusion of blood fails to restore blood pressure. There is multiple organ failure and depression of cellular high energy phosphates. Finally, cardiac failure occurs due to decreased myocardial activity and decreased arterial tone. If low perfusion state persists, irreversible shock leads to death. Non-progressive, which is the initial compensated and reversible shock. In the initial stages of shock, an attempt to maintain adequate cerebral and coronary blood supply by redistribution of the blood so that the vital organs, which are the brain and the heart, are adequately perfused and oxygenated is done. This is achieved by activation of various neurohormonal mechanisms, causing widespread vasoconstriction, and by fluid conservation by the kidney. Clinically, in progressive shock, there is hypotension, oliguria, tachypnea, acute respiratory distress syndrome, which is ARDS, caused by pulmonary hypoperfusion, acidosis due to anoxia of liver causing reduced clearance of lactate. Fluid conservation by the kidney is done by release of aldosterone from the hypoxic kidney, release of ADH due to decreased effective circulating blood volume, reduced glomerular filtration rate, shifting of tissue fluid into plasma due to lowered capillary hydrostatic pressure. Progressive decompensated shock. This is a stage when the patient suffers from some stress or risk factors besides persistence of the shock, so that there is progressive deterioration. Decompensated or irreversible shock. At this stage, the patient has features like coma, worsen heart function, and progressive renal failure. It is characterized by irreversibility of shock with tissue anoxia. Occupying central role of these are under persistence of widespread vasoconstriction, vasodilatation, and increased vascular permeability, myocardial ischemia, cerebral ischemia, vasodepressor material, tumor necrosis factor, intestinal factors, bacterial factors, and hypercoagulability of. Moving on to the classification of shock, it may be hematogenic or hypovolemic shock, septic shock, cardiogenic shock, traumatic shock, neurogenic shock, or miscellaneous shock, which may be anaphylactic or insulin shock. Hypovolemic shock results from blood loss or plasma volume. This may be caused by hemorrhage, fluid loss from severe burns or trauma, usually occurs from small veins and systemic venules. The clinical features of mild shock include less than 20% loss of volume, collapse of subcutaneous extremities, which causes them to be pale and cool. There is sweat on the forehead, palms, and feet. Urinary output, pulse rate, and BP are normal. In moderate shock, there is 20 to 40% loss of blood volume. There is mild shock plus oliguria. Pulse rate is increased but less than 100. BP remains normal but falls in the later stages. In severe shock, there is greater than 40% loss of volume. There is pallor and low urinary output and a rapid but low pulse rate. Treatment, resuscitation, control of bleeding, extracellular fluid replacement. If there is blood loss, it is best replaced by blood. Blood substitutes cannot replace blood. Septic shock. It is caused by systemic responses to severe infections. It occurs most frequently in elderly or immunocompromised patients or those who have undergone invasive procedures in which bacterial contamination has occurred. Overview of septic shock. Septic shock is the most common cause of mortality in the intensive care unit. It is the 13th leading cause of death overall. The mortality rate ranges from 15% in patients with sepsis to 40 to 60% in patients with septic shock. There is a continuum of clinical manifestations from SIRS, sepsis, severe sepsis, septic shock to multiple organ dysfunction syndrome. In these instances, widespread vasodilation causes a sudden increase in the vascular bed capacitance, which is not adequately filled by the normal circulating blood volume. Hypotension, tissue hypoperfusion, and cellular anoxia are caused as a result. Patients go into shock and even die within the hour. The risk of anaphylaxis must be borne in mind when certain therapeutic agents are administered, because although patients at risk can generally be identified by previous history of some form of allergy, the absence of such history does not preclude the possibility of an anaphylactic reaction. The etiology, it is most commonly occurred in setting of gram-negative and gram-positive infections through any agent that is capable of producing infections like viruses, fungi, or parasites. Most common organisms which cause septic shock are E. coli, Klebsiella, Proteus, Pseudomonas, and bacteroids in decreasing frequency. Pathophysiology. Sepsis is triggered by bacteria or fungi that ordinarily do not cause systemic diseases in immunocompetent hosts. These microbes exploit the deficiency in host defenses to survive in the body. Pathogens in turn overcome the defenses by elaborating toxins or other virulence factors, and when the body fails to kill these invaders, it mounts to a severe sepsis. Animals have exquisite mechanisms for recognizing and responding to conserved microbial molecules. The endotoxins of a gram-negative bacterial cell wall is the best example. The lipopolysaccharides present on the cell wall account for their endotoxic activities. These consist of three regions: the region 1, which is the polysaccharide portion, region 2, the core polysaccharide, and region 3, the glycolipid, lipid A, which is responsible for endotoxic activity. Engagement of TLR on endothelial cells can lead directly to downregulation of natural anticoagulation mechanisms. There is profound mononuclear cell activation. Presumably, this series of responses helps to isolate organisms to trigger elements of the immune system to efficiently eradicate invading microbes. Unfortunately, depending on the dosage and the number of macrophages that are activated, the secondary effects of LPS release can also cause severe pathological changes, including fatal shock. At low doses, LPS predominantly serves to activate monocytes and macrophages with effects intended to enhance their ability to eliminate the invading bacteria. With moderately severe infections, and therefore with higher levels of LPS, cytokine-induced secondary effectors become significant. Systemic effects of the cytokines such as TNF and IL-1 may begin to be seen. Fever and increased synthesis of acute phase reactants occurs. Still higher levels of LPS. The syndrome of septic shock supervenes the same cytokines and secondary mediators, and now at high levels, this results in systemic vasodilation, which causes hypotension, diminished myocardial contractility, widespread endothelial injury and activation, causing systemic leukocyte adhesion and pulmonary alveolar capillary damage. Activation of the coagulation system, culminating in disseminated intravascular coagulation. Skin remains warm, pink, and well perfused. Cutaneous veins remain full. The pulse rate is high. There is intermittent spikes of fever with bouts of chills. The treatment of infection by early surgical debridement or drainage and appropriate antibiotics. Then treatment of shock is given by fluid replacement and steroids. Traumatic shock, it may be caused by major fractures, crush injuries, burns, extensive soft tissue injuries. Hypovolemia due to bleeding externally and internally, and due to toxic factors resulting fragments of tissues enter the bloodstream. These traumatized tissues activate coagulation cascade and release microthrombi into the circulation. They occlude the pulmonary vasculature. Microthrombi include a generalized increase in capillary permeability. There is loss of plasma into the interstitial tissue throughout the body, and this depletes the vascular volume to a great extent. The clinical features are similar to those of hypovolemic shock. Two differentiating features are the presence of peripheral and pulmonary edema in traumatic shock and infusion of large volumes of fluid, which may be adequate for pure hypovolemic shock. It is usually inadequate for a traumatic shock. The treatment includes resuscitation, local treatment of the trauma and control of bleeding, fluid replacement, full body anticoagulation, which we give one IV dose of 10,000 units of heparin. Cardiogenic shock. This is caused by injury to heart, myocardial infarction, cardiac arrhythmias. Due to right ventricular dysfunction, the right side of the heart is unable to pump blood into the lungs in adequate amounts. This causes the filling of the left side of the heart to decrease. Left ventricular output decreases, and this causes compressive cardiac shock. Due to left ventricle dysfunction, it is unable to maintain adequate stroke volume. There is engorgement of pulmonary vasculature due to normal right ventricular output but failure of the left heart. When the heart is compressed enough from outside to decrease the cardiac output due to pneumothorax, pericardial tamponade, etc. Clinical features. Initially, the skin is pale and cool, the urine output is low, pulse becomes rapid, and arterial blood pressure is low. Right ventricular dysfunction causes neck veins to distend and liver to enlarge. Left ventricular dysfunction causes bronchial rales to be heard. Gradually, the heart gets enlarged and later the neck veins are also distended. Treatment for cardiogenic shock is airway has to be cleared with adequate oxygenation. Large doses of IV heparin is given, and for pain, morphine is given. Neurogenic shock caused by paraplegia, quadriplegia, trauma to spinal cord or spinal anesthesia, loss of arterial and venous tone with pooling of blood in dilated peripheral venous system. The heart does not fill normally and CO falls. Clinical features. The skin is warm, pink, and well perfused. Urine output may be normal. Heart rate is rapid and BP is low. The treatment is to elevate the legs, administer fluids, and vasoconstrictor drugs. Distributive shock occurs when the blood volume is normal but the capacity of circulation is increased by marked vasodilation. It is also known as warm shock, as the skin is not cold and clammy as it is usually in hypovolemic shock. Example of distributive shock may be anaphylactic shock and neurogenic. Anaphylactic shock, it is an allergic condition in which the cardiac output and arterial blood pressure often fall dramatically, a rapidly developing severe allergic reaction that sometimes occurs when an individual who has been previously sensitized to the antigen is exposed to it again. The clinical features include warm peripheries and low blood pressure, erythema, urticaria, angioedema, pallor, cyanosis, bronchospasm, rhinitis. There is edema of the face, larynx, and pharynx, pulmonary edema, hypovolemia, which is caused due to capillary leak, nausea, vomiting, and abdominal cramp. Anaphylactic shock in humans. Their systemic anaphylaxis may occur after administration of foreign proteins like antisera, hormones, enzymes, polysaccharides, and drugs, such as the antibiotic penicillin. Initiated by a generalized IgE-mediated hypersensitivity response, it is said to be due to increased histamine released by the combination of antigen with IgE on mast cells and basophils. The severity of the disorder varies with the level of sensitization that has occurred. Extremely small doses of antigen may trigger anaphylaxis. Within minutes after exposure, itching, hives, and skin erythema appear, followed shortly by striking contraction of respiratory bronchioles and respiratory distress. Laryngeal edema results in hoarseness. There is vomiting, abdominal cramps, diarrhea, and laryngeal obstruction, followed by systemic vasodilation and increased vascular permeability. Burn shock. The most apparent abnormality in this is the loss of plasma as exudates from burn surface. So there is an increased hematocrit and hemoconcentration found. There is complex metabolic changes which are seen in such patients. Biochemical changes seen are electrolyte imbalance, hypoproteinemia, hyperglycemia, increased blood urea creatinine levels due to kidney damage and extensive burns. And the changes in burn are hemoconcentration due to outpouring of the serum, increased number of RBC due to outpouring of serum. There is sludging of blood and this causes intravascular agglutination, an abrupt fall in eosinophil count during the first 12 hours which slowly begins to increase. There is increased blood viscosity. Hypoadrenal shock. The normal host response to the stress of illness, operation, or trauma requires that the adrenal glands hypersecrete cortisol in excess of that which is normally required. So hypoadrenal shock occurs in settings in which the unrecognized adrenal insufficiency complicates the host response to stress induced by acute illness or any major surgery. The treatment for shock generally includes blood transfusion, plasma transfusion, administration of plasma substitutes, administration of sympathomimetic drugs, including epinephrine or norepinephrine, administration of glucocorticosteroids, oxygen therapy, and by changing the posture of the patient. Thank you.